Hello, I am Professor Jong Jae-yoon from Periodontics Department at Seoul National University Gwanak Dental Hospital. It is a pleasure to greet the Denal TV viewers today through Journal Inside. Today's review article was published in COIR last year, and it summarizes the effect of soft tissue thickness on peri-implant marginal bone level at the time of implant placement. By looking into this review article, we will think about the meaning and importance of peri-implant soft tissue. For a healthy implant, marginal bone stability has long been considered one of the most important factors. Marginal bone loss around implants can be categorized into early marginal bone loss and late marginal bone loss. Early marginal bone loss is part of the remodeling process unrelated to infection and may occur to achieve biologic width. It is also influenced by the width of the bone around the implant. In contrast, late marginal bone loss is usually considered to be bone resorption caused by infection, such as peri-implantitis. To maintain a stable marginal bone level, which is essential for a healthy implant, it is now widely agreed that a healthy peri-implant soft tissue is necessary. A healthy and sufficient amount of soft tissue will attach to the periphery of the implant abutment and serve as a biologic barrier to protect peri-implant tissue from microorganisms. The peri-implant soft tissue is very akin to the periodontal tissue, but the collagen fibers run parallel to the implant, so the acute bone strength is a little weaker. However, the peri-implant soft tissue plays a similar role to periodontal tissue's gingiva. Just as the biologic width in natural teeth, including 2 millimeters of attached soft tissue, the implant has a certain soft tissue attachment that helps protect the inner structures from external factors. This is the soft tissue around an implant with the abutment removed. The attached connective tissue and sulcus are observed well. Implant also needs an appropriate thickness of soft tissue, as it plays a critical role in protecting peri-implant tissue, just like the biologic width in natural teeth. Although it varies by individual, when examining the necessary amount of soft tissue attachment, soft tissue thickness of about 2 to 3 mm, including sulcus depth, for a tooth and 3 to 4 mm for an implant is needed. A well-known study by Berglund and Linde in 1996 examined what happens when appropriate soft tissue dimensions are not achieved. They observed when the gingiva was thinned down to 2 millimeters. The crestal bone loss occurred to secure soft tissue dimensions. In the case of thin soft tissue, along with bone loss, about 2 millimeters of junctional epithelial attachment and 1.5 millimeters of connective tissue attachment occurred. Similar in the case of 4 millimeters thick soft tissue. This confirms that when the implant depth is shallow or soft tissue is thin, marginal bone loss can happen even without infection to secure 3 to 4 millimeter of soft tissue. These days, height of peri-implant soft tissue, which was mentioned before, buccolingual thickness, the amount of keratinized gingiva and thickness of alveolar bone around the implant are all called peri-implant phenotype. There are active studies going on about the peri-implant phenotype, such as the minimum required keratinized gingiva, mucosal thickness, and the thickness of soft tissue to ensure health. Peri-implant tissue, as well as research on the correlation between peri-implant soft tissue and bone tissue and how to reduce peri-implant bone loss through soft tissue augmentation. The review article for today also evaluates the effect of soft tissue thickness, one of the peri-implant phenotype, on the initial bone remodeling. Then, let's take a look at the methodology. The targets are randomized control trial and controlled clinical trial among human studies published up until May 2022. These studies were conducted on systemically healthy individuals, each having at least one implant placed. They observed the relations between soft tissue thickness, measured using probes or endodontic files, and changes in marginal bone level over at least 10 to 14 months. On the other hand, some cases were excluded from the study if the implant was placed immediately after tooth extraction, if immediate loading was performed, or if soft or hard tissue grafting was involved. 6 studies were then selected. A total of 354 implants were evaluated in the 6 studies. The soft tissue thickness prior to implant placement was more than 2 millimeters in 194 implants and less than 2 millimeters in 160 implants. However, there are a few things to consider when we review the study results. As for implant placement method, bone level and tissue level are all mixed up, and the placement depth was not controlled either, despite being an important factor affecting the initial bone remodeling. So we should take the results with these factors in mind. As expected, there was about a 0.5 millimeter difference in marginal bone level between thick and thin soft tissue cases at the time of implant placement. In other words, there was less early marginal bone loss in the thicker soft tissue. Other than that, patient age, follow-up period, etc. did not have a significant impact. However, initial bone remodeling can be affected by not just thickness of soft tissue, but also other various factors. Flap opening or flapless approach, drilling protocol, implant positioning, the prosthetic procedure, crown design, and pre-operative alveolar crest dimension can all impact the results. Here, soft tissue thickness can be added as another factor. Let's say we will have to deal with a patient with these conditions. The alveolar bone is not wide enough, and the soft tissue is very thin as seen on the CT. The distance to the inferior alveolar nerve is not enough either, so we decided to skip implant placement for number 37. In a case like this, the implant should be placed as deep as possible to ensure adequate soft tissue thickness and height, but due to the proximity to the nerve, that wasn't possible. Loading was performed, and this is an X-ray taken about a year later. We can find quite a bit of crestal bone loss that appeared to be early marginal bone loss. I lifted a flap and found that the implant was exposed due to marginal bone loss, and a lot of plaque was formed inside like this. This was bone loss caused by remodeling and infection. Bone grafting was performed, and the case is under follow-up, but there is still a risk of further marginal bone loss. This is because an appropriate amount of soft tissue was not secured in the first place, so that risk will continue to be there. This study confirmed that soft tissue thickness can influence initial peri-implant bone remodeling. But more importantly, I think we should look into further studies on the correlation between the thickness of soft tissue and the long-term peri-implant bone loss. To secure an appropriate depth of soft tissue, we also have to consider placing an implant more deeply, or performing some additional procedures such as soft tissue grafting. I hope today's journal review provided valuable insights that can help your clinical practice. That concludes my presentation. Thank you for watching.